So good afternoon, I think, everyone now. I'd just like to start actually by thanking Max and his team for organising this workshop. I mean, in my view, it's actually long overdue that we had a workshop on TASP that focuses on TASP in Africa and that is located in Africa. So I'd really like to thank you for that. It's a very useful initiative. Thank you. I hope we all agree. So this is a joint presentation by Helen Ailes and myself on the HPTN 071 PopART trial. That stands for Population Effects of Antiretroviral Therapy to Reduce HIV Transmission. So what we plan to do is to give you a brief overview of the trial design for those of you who have not seen this before. I'll briefly update you on the timelines for this study, which have changed over time because of the various delays we've suffered. And then Helen and I will outline the progress that's been made over the last couple of years. And then Helen will be giving you some very informative feedback, I think, on the challenges that have been faced, particularly in the field, as we've begun to deliver this study. So a brief overview of the trial design. Again, apologies for those of you who've seen this many times before. It's a cluster randomized trial in 21 communities in Zambia and South Africa. It has 3 arms, not 2. Arm A will receive the full combination prevention package that we call the PopART package, which will include the offer of immediate ART irrespective of CD4 count. At the other end, we have Arm C, which is the control arm, which will continue to receive the standard of care at current service provision levels in these communities. And that includes ART initiation according to the current national guidelines. The middle arm, Arm B, will receive the full combination prevention package with one exception, which is that ART will continue to be initiated according to current national guidelines. Incidentally, up until recently, the national guidelines in both countries were still using a CD4 threshold of 350, but over the last couple of weeks, Zambia has announced that it is moving to the new WHO recommendations. So that will be a threshold of 500 in Zambia, but in South Africa, it's still 350. To measure, we have 21 communities altogether, as I mentioned. That's 12 in Zambia, 9 in South Africa, and these are arranged in 7 matched triplets that have been randomly allocated to the 3 study arms. And to measure the impact of the intervention, we are enrolling a population cohort, which consists of a random sample of 2,500 adults in each cluster, a total of 52,500, and they will be followed up every year for a total of 3 years. So that's 4 surveys altogether, baseline, 12 months, 24 months, and 36 months. I should mention that these communities are quite large communities. They're essentially the catchment population of a government health facility that delivers ART. The average population size is about 50,000, although they vary quite a lot. So actually the total population covered by our whole trial is about 1.2 million. So we're talking about quite a large population. I just want to take you quickly through the combination prevention package, the PopART package. And at the heart of this package is what we call the CHIPS. This stands for Community HIV Care Providers. This is a cadre of community health workers who've been specially trained to deliver these services at household level. And they have a number of responsibilities. Key one at the top here is the universal testing and counselling program, which is delivered through a home-based service, door-to-door service. And that will be repeated at annual intervals. So the principle is that everyone in the community should test, and they should retest at annual intervals if they're still HIV negative. The CHIPS will also promote services for those, whether they're HIV negative or positive, and will refer to the appropriate services for the delivery of these of this care. So for HIV positives, this includes a linkage to the local health facility down here for offer of ART. That includes linkage to services for prevention of mother-to-child transmission for pregnant women. For HIV negative men, they will be promoting male circumcision and referring to appropriate local services. There will be a symptom screen for TB, and again, linkage to the clinic for further diagnosis and treatment if necessary, and similarly for symptoms of sexually transmitted infections. At the health centre, in Arm A, there will be the offer of immediate antiretroviral therapy irrespective of CD4 count. In the other two arms, treatment will continue to be given according to national guidelines. And then importantly, the chips will also be returning to to each of the households in their zone at regular intervals. They'll be doing follow-up to check that people have got to the clinic, to provide further promotion of care if necessary, and of course after a year to carry out the retesting and so on. And they will also be responsible for supporting retention in care and for adherence support. This is just a map showing the geographical location. So on the left-hand side, you see Zambia, and the triangles show the 12 study communities right across Zambia. This is a large area, several hundred kilometers. So one of the challenges for us that Helen might mention is just the very large distances we're dealing with. In South Africa, we're working in a much more confined area in the Western Cape area near Cape Town. There's 9 communities there. The outcome data we'll be measuring, that's partly from our population cohort, which, to remind you, is a random sample of adults aged 18 to 44. And you can see the main outcome variables here. So HIV incidence is the primary outcome. HSV2 as a marker of sexual behavior to look at sexual risk disinhibition. We'll also be looking at ART retention, adherence, and viral suppression. We'll be getting a measure of community viral load to look at how that changes as a result of this intervention. Drug resistance, reported sexual behavior to look at disinhibition again, and then a whole lot of measures of HIV-related stigma, which we hope this intervention will be reducing. And then based on process data from the CHIPs and from the clinics, we'll be looking at uptake of the different intervention components, delay in getting into care, retention in care and adherence, HIV disease progression and mortality, toxicity, and then also TB based on notification of TB cases and mortality through clinic-based data. We always show this slide, although I think we're probably preaching to the converted here, but we think it's very important to keep reminding ourselves of why this trial and the other major combination prevention studies are actually needed. And we think these are the main reasons. So firstly, we think it's not known yet whether it's actually feasible to deliver this kind of universal test and treat strategy with adequately high uptake and acceptability. We think that although there have been many mathematical modeling projections of the impact this will have, the different models show very different projections. There's many uncertainties in those model parameters, and so we think that empirical studies are needed to actually measure the population level impact that you can get from this kind of intervention. We think that as well as the potential benefits, then there are many potential adverse effects, such as toxicity, drug resistance, as we've discussed this morning, the possibility of sexual risk disinhibition that might partly outweigh some of the benefits from the ART. We hope that stigma will be reduced, but that needs to be tested. And the concerns already expressed this morning about the possibility of overloading health services that are already struggling to provide treatment to those who urgently need it. And so, as we've heard, there are actually many debates and uncertainties about the costs and benefits of moving to higher thresholds for onset of treatment, and also, what resources should be put into the other key component of universal test and treat, which is the testing component. And we've heard, there were concerns about the cost and feasibility of home-based testing and counselling. So we argue that we need rigorously designed and conducted studies, both PopART and other studies, to really measure the costs and the benefits of this strategy so that health policy makers can then make rational decisions about whether this should be implemented on a very wide scale. Just to mention briefly that there's a whole range of additional studies being carried out within the framework of the PopART trial. We have a very good team of mathematical modelers based at Imperial College who helped to design the study and also will be helping us to continue with the modelling as the study progresses. They'll be looking at the various process measures as they are available and looking to see whether we need to make modifications either to the design of the intervention or the outcome evaluation. And at the end of the trial, their work will be very important in trying to understand the various results that we get. We also have a good team of health economists because we recognise the importance of cost effectiveness studies in the context of these big trials. We've also got an excellent qualitative research team, and we think that this is really key to understand how these interventions are received and accepted in the communities, to identify problem areas, to look at issues around key populations and whether special services are needed, and to explore stigma, for example, in more depth. We're also carrying out some detailed case control studies looking at factors associated with uptake of the different intervention components. And there are a number of ancillary studies. The first two of these are already funded, and we're hopefully proceeding with those. One using phylogenetics to look at ongoing patterns of transmission in these communities to help us understand the study results, and a detailed study looking at stigma, including HIV-related stigma, which will link in with our qualitative research. And we're hoping to get additional funding to look at the impact of this intervention on TB prevalence through a community-based prevalence survey of TB, and also to look in more detail at the impact of this intervention on vertical transmission and on HIV-free infant survival. We've suffered a few delays in the onset of the study. You won't be able to see the details of this, but I'll just mention the key aspects of the modified timeline. We're somewhere around about here in the early part of 2014. So we're currently going through the first round, both of the intervention, which is this bar here, and of the enrollment survey for our population cohort. And there will then be 3 further rounds at annual intervals for both the testing and counselling components of the intervention and follow-up of our population cohort. I won't go into the details of these other components here. So as things stand currently, the trial will end during 2017 here. And finally, before I hand over to Helen, just an overview of progress. So the approvals of the main study, that took some time to get those through, but that was completed in May last year. The ancillary studies are still going through the approvals procedures. We hope to have that completed in the next few months. We completed our randomization ceremony of the 21 communities in February 2013 in an open ceremony attended by community representatives in both countries simultaneously. In terms of research activities, the formative research has been completed, and Helen will briefly summarize that, as are the community-level censuses that were used to enumerate the populations and to form a sampling framework for our population cohort. As I've said, the cohort enrollment is now underway, as are the intervention activities in all communities, both at community level through the CHIPs and at clinic level. And Helen will mention a little bit about the meetings and governance. So I'm going to hand straight over to Helen.